lung allocation has undergone two major changes in the last couple decades. First, with the implementation of the lung allocation score as the primary determinant of donor lung allocation in 2005, and second, the change to the primary geographic allocation unit back in 2017. Both these modifications helped improve the allocation system. Now, the lung allocation system helped reduce waitlist mortality and improve the efficiency of donor lung allocation. And since our last discussion, there have been further modifications to the lung allocation score, and I believe your research had some bearing on this. And in my readings, terms such as composite allocation score and continuous distribution scoring powered by AI are now being used. Can you tell us how this latest modification of the lung allocation system has impacted patients seeking transplantation?
Of course. Thank you again for the invitation to join you on this podcast. As you've already stated, in 2005, the lung transplant system for organ allocation transitioned to the LAS, which allowed us to prioritize the sickest patients for access to transplant. In nearly 20 years since its implementation, not only have we collectively become better at taking care of complex patients, but we've also become better at managing donors using advanced techniques, which you will discuss with Dr. McCurry. Now we don't need to have these strict bounds for geographic distance between the candidate and donor hospitals like we did in the past. So it was in response to these new realities that came the 2017 incremental change that would allow us to slightly broaden geographic sharing of donor lungs. The composite allocation score, or the CAS system, represents kind of the next step where we're marrying these two priorities. Here, we broaden our geographic reach in direct proportion to how sick a waitlisted candidate is, or how difficult it is to find an organ for them based on their biological variables. The CAS was implemented a year ago in March of 2023. A year later, we have two important trends that I think matter most to patients and their physicians. That is, we are transplanting more candidates now, and we have less patients dying on the waiting list. And that's likely because now we are more effectively accounting for biological barriers that limited access for certain groups of patients. And we've also broadened the geographic reach of our sickest patients so they can access transplant in a timely manner.
Another thing that came up at the time of our last discussion had to do with the importance of primary graft dysfunction and rejection, chronic inflammation causing rejection. And I was wondering if Dr. McCurry could bring us up to date on any changes in how these patients are monitored or the development of chronic graft rejection testing and whether there's been improvement in management of the condition over the last several years.
Yeah, so thank you, Dr. Rizzo. Yeah, this is really interesting area of research, and I think in particular, chronic rejection, and Dr. Valapour can attest to this as well, and perhaps speak to it a little bit after I finish. But chronic rejection really remains sort of the scourge of transplantation in general. So if you look at all the organs that we transplant, they're all subject to this chronic attrition of graft loss related to chronic allograft rejection. Indeed, if you look at survival contingent on 1 year survival, the curves from that point really haven't changed much in the 25 years that I've been involved in the field. So there's this continual attrition due to CLAD, what we term CLAD, chronic lung allograft rejection, which is essentially the form of chronic rejection that we see in lung transplants. And if you look at all the organs that we transplant, the two that are most susceptible to this and have the worst long-term outcomes are the lung and the intestine. And I think many of us conjecture that perhaps it's due to the fact that both of these organs are quite complex, and they're both exposed to the external environment. So they're subject to the rigors of infection and a variety of other things like that. We've known for a long time that there are a number of factors that are associated with developing CLAD. We've sort of typically classified those into immune and non-immune mediated factors. Immune being obviously rejection, both T and B cell responses, non-immune being reflux and the risk of aspiration, as well as primary graft dysfunction, which occurs essentially from ischemia, reperfusion injury around the time of the transplantation. I think increasingly there's a lot of evidence that perhaps the pathogenic mechanism that might link these together is inflammation and ongoing inflammation in the graft. And there's a lot of new data looking at the lung microbiome in particular, and I think this is just a super interesting area of research right now, looking at the lung microbiome and changes both in the burden and in the community of organisms in the lung and how those impact outcomes. And I'm sure as you and your audience are both well aware, there's a lot of data now in non-lung transplant, both acute and chronic lung disease, where the lung microbiome, changes in the lung microbiome is associated with progression in the disease and risk of mortality. And there's some early compelling data now in lung transplantation that's being investigated. So really a super interesting area of research, and at least these initial papers, it appears to be independent of these other risk factors that I've mentioned.